Assalamualaikum and good day to everyone. My name is Abdul Rahim and I will be presenting about acute otitis media and chronic suppurative otitis media. Acute suppurative otitis media is defined as an acute inflammation of the middle ear cleft by pyogenic organisms. It occurs more commonly in infants and children of lower socioeconomic group and usually follows viral upper respiratory tract infection and invasion by pyogenic organisms. The routes of infection can be divided via eustachian tube, external ear, or blood-borne. The eustachian tube is the most common route where infection travel via lumen of the eustachian tube or along subepithelial peritubal lymphatics. Higher incidence of infection in infants and children can be attributed to the anatomy of the eustachian tube, which are generally shorter, wider, and more horizontal compared to adults. Hence, breast or bottle feeding in a horizontal position may force fluids through the eustachian tube. Similarly, swimming and diving can also force water through the eustachian tube. Secondly, via the external ear, where a traumatic perforation of tympanic membrane due to any cause can lead to middle ear infection. And thirdly, through blood-borne, however, this route is uncommon and can be seen in cases of tubercular or syphilitic otitis media. The risk factors can be divided into social and disease factors. Social factors include young age, where it's commonest in less than 2-year-old patients, family history of otitis media, bottle feeding in horizontal or supine position, poor socioeconomic status, and presence of smokers in the family. Disease factors, on the other hand, include any factors that may contribute to eustachian tube dysfunction, for example, skull-based deformities or craniofacial abnormalities, recurrent URTI, prolonged rise tube insertion, underlying uncontrolled allergic rhinitis, chronic rhinitis and sinusitis, immunological disorders such as IgA or IgG production disorder, ciliary dysfunction, GERD, infections of tonsils and adenoids, adenoid hypertrophy, and nasopharyngeal mass. Most common organisms in infants and young children are strep pneumoniae, Haemophilus influenza, Moraxella catarrhalis, and others such as Strep pyogenes, Staph aureus, and Pseudomonas aeruginosa. However, in 18 to 20% of the cases, no growth is detected. The clinical features can be divided into stage of hyperemia or tubal occlusion, presuppuration, suppuration, resolution, and lastly, complication. Progression of these stages depends on the virulence of the infecting organisms, its resistance to hosts, and the adequacy of antibiotic therapy. In stage of hyperemia or tubal occlusion, as the name implies, there is edema and hyperemia of the nasopharyngeal end of the eustachian tube, causing blockage of the eustachian tube, leading to absorption of air and negative intratympanic pressure. As a result, there will be a retraction of TM with some effusion in middle ear but may not be appreciated clinically. Possible symptoms experienced during this stage include deafness and mild otalgia, and patient is generally afebrile. Signs that can be seen include retracted TM, the appearance of a more horizontal handle of malleus, prominence of lateral process of malleus, and loss of light reflex. Tuning fork tests will show conductive deafness. If tubal occlusion is prolonged, pyogenic organisms may invade tympanic cavity, causing hyperemia and congestion of the TM lining with presence of inflammatory exudates. Symptoms include marked otalgia, deafness, tinnitus, high-grade fever, and restless in children. On examination, there may be congestion of pars tensa with the appearance of leash of blood vessels along handle of malleus and at periphery of TM, giving it a cartwheel appearance, with hyperemia of pars flaccida. Tuning fork test will also show conductive deafness. In stage of suppuration, there is formation of pus in middle ear or mastoid air cell, where TM will start bulging to the point of rupture. Patient may experience excruciating otalgia, worsening deafness, and children may have high-grade fever, convulsions, or vomiting. Several signs can be identified, such as red and bulging TM with loss of landmarks, engulfed handle of malleus by the swollen and protruding TM. Yellow spot may be seen, which may indicate rupture, and tenderness at mastoid antrum. In stage of resolution, TM will rupture with release of pus and symptoms will subside. If proper treatment is started earlier or infection was mild, resolution may start without rupture of TM. Otalgia is relieved with evacuation of pus, fever subsides, and child feels better. The EAC may contain blood-tinged discharge, which later becomes mucopurulent. Small perforation usually can be seen at inferior quadrant of pus tensa, and hyperemia of TM subside with return to normal color and landmarks. If virulence of organism is high or patient's resistance is poor, resolution may not take place and the disease may spread beyond the middle ear. Complications include acute mastoiditis, subperiosteal abscess, facial paralysis, labyrinthitis, petrositis, extradural abscess, meningitis, brain abscess, or lateral sinus thrombophlebitis. Antibiotic is indicated in all cases with fever and otalgia, where a minimum of 10 days is required until TM and hearing returns to normal. Inadequate doses may lead to secretory otitis media and residual hearing loss. Decongestant nasal drops such as Afrin and Iliadin can be prescribed to relieve ET edema and promote ventilation of middle ear. Additional medications that should be prescribed include H1 antihistamines such as chlorpheniramine, cetirizine, levocetirizine, loratadine, or desloratadine. Paracetamol is used to relieve pain and fever in addition to proper ear toileting. Incision of the TM to evacuate pus or myringotomy may be indicated when TM is bulging with acute pain or incomplete resolution despite antibiotic, where TM remains full with persistent conductive deafness or persistent effusion beyond 12 weeks. In conclusion, all cases of acute suppurative otitis media should be followed up until the TM returns to normal appearance and conductive deafness disappears. Now let's move on to acute necrotizing otitis media, which is a variety of ASOM, often seen in children suffering from measles, scarlet fever, or influenza. It is caused by beta hemolytic streptococcus, characterized by rapid destruction of whole of TM with its annulus, mucosa of promontory, ossicular chain, and mastoid air cells. Patient may complain of profuse otorrhea, and its healing is by fibrosis or ingrowth of squamous epithelium from meatus, a condition also known as secondary acquired cholesteatoma. This figure is showing the treatment of acute otitis media, where we can see that antibacterial therapy should be started early with minimum of 10 days duration with proper reassessment of symptoms and periodic checkup up to 12 weeks. Persistent effusion beyond 12 weeks will lead to a condition called otitis media with effusion. So what is otitis media with effusion? It is a gradual and cumulative condition characterized by accumulation of non-purulent effusion in middle ear cleft, where effusion may be thick and viscid or thin and serous. Etiologies include malfunctioning of ET or failure to aerate or drain fluid in the middle ear, such as in cases of adenoid hyperplasia, nasopharyngeal tumors, or palatal defects, and an increase in secretory activity seen in allergies, unresolved otitis media, or viral infection by adenovirus or rhinovirus. Symptoms of OME include hearing loss, which rarely exceeds 40 dB, delayed or defective speech, and mild otalgia. Examination may reveal dull and opaque TM with loss of light reflex, varying degree of TM retraction, or full or slightly bulging TM in its posterior part due to effusion. Fluid level and air bubbles can be seen when fluid is thin and TM is transparent. And lastly, mobility of TM will be restricted. Tuning fork shows conductive hearing loss. PTA conductive hearing loss 20 to 40 dB. Sometimes may be associated with sensory neural hearing loss due to fluid pressing on the round window membrane, which disappears with evacuation of fluid. In impedance audiometry, presence of fluid is indicated by reduced compliance and flat curve with shift to negative side. Treatment for OME can be divided into medical and surgical. Medical treatment is similar to ASOM, while surgical treatment include myringotomy, as mentioned earlier, grommet insertion, tympanotomy or cortical mastoidectomy, and surgical treatment of underlying causative factor. The consequences of OME include atrophic TM and atelectasis of the middle ear, ossicular necrosis, where it most commonly affects long process of incus, sometimes stapes superstructure, which increases conductive hearing loss to more than 50 dB, tympanosclerosis, retraction pocket and cholesteatoma, and lastly, cholesterol granuloma, which is characterized by a mass of granulation tissue with foreign body giant cells surrounding cholesterol crystals. It is caused by reaction to long-standing retention of secretions or hemorrhage. It is also called chocolate cyst or blue dome cyst. It is prone to bleeding and causes hemotympanum, where it may appear blue behind an intact TM. Now let's move on to CSOM. It is a long-standing infection of a part or whole of the middle ear cleft characterized by otorrhea and permanent perforation. A perforation becomes permanent when its edges is covered by squamous epithelium and does not heal spontaneously. Common aerobes involve Pseudomonas, Proteus, E. coli, and Staph aureus, while common anaerobes involve Bacteroides fragilis, and Strep species. This figure is showing the possible location of perforation of TM where it can occur at pars tensa or pars flaccida. We can see perforations in pars tensa can be divided into central and marginal perforation. In central perforation, the perforation is described in relation to the handle of Malleus, while in marginal perforation, the perforation destroys even the annulus and reaches sulcus tympanicus, and it may be described as posterior-superior, anterior, inferior, or total, where posterior-superior marginal perforation is the most common. And not to forget, perforation of the pars flaccida is also known as attic perforation. This figure shows the type of perforation in the TM seen in CSOM, where you can see central perforation, central anterior, central perforation, perforation medium size, subtotal perforation, total perforation with destruction of even the fibrous annulus, attic perforation, and posterior superior marginal perforation. CSOM can be divided into tubotympanic type or mucosal disease and aticoantral type or squamosal disease. Tubotympanic type occurs at antero-inferior part of middle ear cleft near the ET and mesotympanum. Pathological changes that can be seen include perforation of pars tensa. Middle ear mucosa may be normal when disease is inactive or edematous and velvety when active. Pale colored polyp may be observed. Ossicular chain is usually intact and mobile, but may show some necrosis, particularly long process of incus. Tympanosclerosis, impairing the mobility of ossicles, and fibrosis and adhesion, a result of healing process that impairs mobility of ossicles or block the ET. The clinical features in tubotympanic type include otorrhea, which can be non-offensive, mucoid or mucopurulent, constant or intermittent, usually after upper respiratory tract infection or accidental entry of water into the ear. Conductive hearing loss, rarely more than 50 dB. Mixed hearing loss also can occur in cases where cochlea is damaged due to absorption of toxins from the oval and round window. The perforation is always central and visualized middle ear mucosa is normal, pale pink, and moist with occasional polyp. Treatment is by proper ear toileting, ear drops, and systemic antibiotics. We need to advise patients to keep ears dry, use rubber inserts, and avoid nose blowing. Treatment of contributory causes such as infected tonsils, adenoids, and allergies should also be included. Surgical treatment may be needed in removal of oral polyp or granulations or reconstructive surgery such as laryngoplasty with or without ossicular reconstruction. The aticoantral type or squamosal disease alternately is located at the posterior superior part of the middle ear cleft, specifically the attic, antrum, posterior tympanum, and mastoid, and associated with cholesteatoma where it has bone eroding properties. Pathological changes include osteitis, granulation tissue involving the outer attic wall and posterior superior margin of tympanic ring. Ossicular necrosis is common. Occasionally, cholesteatoma form may bridge the gap caused by destroyed ossicles, and hearing loss may not be apparent, also known as cholesteatoma hearer. And lastly, cholesterol granuloma. Otorrhea is usually small in amount but always foul-smelling due to bone destruction. Patients may experience both conductive and mixed hearing loss, and bleeding may occur from granulations or polyp. Perforation is at the attic or posterior-superior marginal type with retraction pocket that can be classified with TOS classification as shown, where grade 1, there is a small attic dimple. Grade 2, the sparse flaccida is retracted maximally and draped over neck of malleus. Grade 3 as grade 2 with erosion of outer attic wall or scutum. And lastly, grade 4, deep retraction with unreachable accumulated keratin. A proper definition of cholesteatoma according to Abramson et al. It is a three-dimensional epidermal and connective tissue structure, usually in the form of a sac, frequently conforming to the architecture of various spaces of the middle ear, attic, and mastoid, and has the capacity for progressive and independent growth at the expense of underlying bone and has the tendency to recur after removal. This is a table summarizing the differences between tubotympanic and atticoantral type, where characteristic of discharge, location of perforation, presence of granulations, appearance of polyp, presence of cholesteatoma, presence of complications, and audiogram result are compared. On examination under microscope, we can observe for granulations, cholesteatoma, associated bone destruction, granuloma, ingrowth of squamous epithelium from edges of perforation, the status of ossicular chain, tympanosclerosis, and adhesions. Culture and sensitivity of ear discharge can be sent. Tuning fork tests and audiogram should be performed. Lastly, HRCT temporal may show extent of destruction caused by cholesteatoma and degree of mastoid pneumatization in atticoantral type of CSOM. Surgical treatment can be divided into canal wall up or canal wall down. Canal wall up is when posterior bony meatal wall is retained, and canal wall down is when mastoid cavity opens into EAC. The table below shows the comparison between these two procedures. Let's look at canal wall up procedure first. The meatus will have a normal appearance. It does not require routine cleaning but has higher rate of recurrent or residual cholesteatoma. It requires second look after 6 months or so to rule out cholesteatoma. Patient has no limitation and allowed swimming. And lastly, easy to wear hearing aid later if needed. Canal wall down procedure, on the other hand, has a widely open meatus communication with mastoid cavity. Dependence on doctor for cleaning mastoid cavity once or twice a year. It has a low rate of recurrence or residual disease and thus a safe procedure. Second look surgery is not required, however, has limitation where swimming can lead to infection of mastoid cavity and problems in fitting a hearing aid due to large meatus and mastoid cavity, which sometimes gets infected. Reconstructive surgery such as myringoplasty or tympanoplasty may be required. Conservative treatment is reserved for patients who have small and easily accessible cholesteatoma, patients unfit for GA or general anesthesia or refusing surgery. In conservative treatment, polyp and granulations are removed using cup forceps or cauterized using silver nitrate or TCA, and repeated suction clearance under microscope with periodic checkups is done. Infratemporal complications of CSOM include mastoiditis, petrositis, facial paralysis, and labyrinthitis, while intracranial complications include extra and subdural abscess, meningitis, brain abscess, lateral sinus thrombophlebitis, or sigmoid sinus thrombosis, and otitic hydrocephalus. Features indicating complications in CSOM, such as pain, where it may indicate extradural, perisinus, or brain abscess, vertigo when there is erosion of the lateral SEC, which may progress to labyrinthitis or meningitis. A fistula test can be done where nystagmus and vertigo is induced by producing pressure changes in EAC. Persistent headache may indicate intracranial complications. Facial weakness suggests erosion of facial canal. Lethargic child refusing feed in cases of extradural abscess, irritability and neck rigidity in meningitis, diplopia in Gradinigo syndrome petrositis, ataxia in labyrinthitis or cerebellar abscess, and lastly, abscess around the ear, which may indicate mastoiditis. With that, thank you for your attention.